A promise of new dawn lies in coming together, being together, and working together, which are perhaps our greatest strength that empowers us peer into the future and impact the shape to healthier and happier tomorrow. Good evening, doctors. On behalf of Team Alchem, we welcome you to the Dentex Webinar Series 2020. We thank you for joining hands with us in our joint mission towards a healthier and happier India. And we thank you for your commitment to strong partnership that brings us together. Over the course of this program, we shall be enriched by wealth of scientific knowledge, the latest advances in the field of dentistry. There will be plethora of insights to dwell on, to discuss, to debate, and finally arrive at a conclusion which we hope will act as catalyst in achieving our shared vision. Dentex has been conceived and coordinated by Dr. Suchetan Pradhan, who is also our scientific program coordinator and is supported by an unrestricted educational grant from Alchem Laboratories, makers of prestigious brands like Clavum, Pan, and Pandy. So, like to welcome Dr. Suchetan Pradhan, our scientific program coordinator. He has over 30 years of experience in the field of dental implantology. He has used virtually all the implant systems available in the market. He has also been invited to lectures extensively and has conducted several workshops in over 25 countries in cosmetic dentistry, laser dentistry, fixed prosthodontics, and implant dentistry, including prestigious Harvard School of Dental Medicine. He has published several papers and authored a chapter on lasers in implant dentistry in the textbook is entitled as Lasers in Dentistry, Current Concepts from Springer International Publishing in 2017. He was visiting professor at Taipei Medical University during 2014 and 17. He is adjunct professor and the director of implant at Laser Dent, and also he has done laser dentistry fellowship program at D.Y. Patil Dental College Hospital in Mumbai. He is also director of Department of Laser Dentistry, Manipal Academy of Higher Education at Manipal. He is international speaker for Nobel Biocare, Destilic, Sirona, and Biolase. He has also been speaker at all world tours, director of Pradhan Dental Center. His area of research focuses mainly on lasers in implant dentistry, aesthetic dentistry, and digital dentistry. He is man blessed with both healing hands and caring heart. We all hope that you have a memorable Dentex. We welcome our scientific program coordinator and speaker of tonight, Dr. Suchetan Pradhan. Over to you, sir.
Thank you very much, Dr. Pawar. And it was quite a task to come on board and do these programs, because remember that in May we had planned that we will do a live in contact session in one of the hotels in Mumbai, which was already booked, and we had to postpone that because of COVID. And so we decided that let's do 3 webinars talking about the advances in clinical dentistry and the latest areas in which a lot of research has been done and a lot of new technologies have been invested and have been used. So once we do this, so the first lecture today will be on digital dentistry, clinical digital dentistry, with all the aspects of digital dentistry. The second webinar, which we are planning to hold on the 20th of next month, which is also a Sunday at the same time, and that will also be on advanced implant dentistry. And I'll give you a little feeler of that today in my presentation. And then the last and the third presentation will be on advanced laser dentistry. So I'll give you a little feel of what we will talk about in that presentation during the course of my lecture today. And that will be on the 16th of October this year. So every month, we're going to do this an hour and a half talking about the latest advances in dentistry. And then we plan to have a contact session, which we had planned for May, in a hotel in Mumbai, which will be a day and a half. And hopefully, with COVID permitting, we could do it sometime early to 2021. So that again is something that is dependent on COVID, as a lot of other things are in today's world. And it will be accompanied by a panel discussion with 2 or 3 presenters and live procedures. So that will be really something to look forward to, because it will showcase the newer techniques and technologies in dentistry. So, having said that, today I'm going to be joined by the moderator, Dr. Siddhant Pradhan, who's an MDS in oral surgery, and he will be taking your questions. So that whatever questions you have, please type it in, and we can take some of your questions during the course of my lecture. We also have a running poll, so you can probably see a dialogue, a little a dialogue box which will say poll. So please, please, please help us fill up that poll box so we know what is the amount of people who are using digital dentistry. And today's poll will be basically only on digital dentistry. So what kind of materials are you using? What cements are you using? Are you using digital scanners in your practices? And so on and so forth. There are about 6 questions that you will have you answer. Please do that for me. It will help us to do a much better for you in the future. Yeah. So let us straight away delve into the presentation. And digital distraction in dentistry is what I call it. So let us look at that in detail. We're going to look at all the aspects of digital dentistry today. You know, with COVID, it's very important that we have patients not coming in too many sittings, too many visits to the dental practices. One is that there is a fear that they will be interacting with a lot of people, and so you want to minimize the number of visits that the patients will make into your practice. And digital dentistry will enable you to do that with even single visit dentistry with the milling units that you can actually have in your practices. Digital distraction is less understood. People think that digital dentistry is all about just scanning. Let me tell you, scanning is only 5% of digital dentistry. So let's look at it in the entire perspective. It's an illusion you create. That is digital distraction. So that's my little CV in short. Dr. Roshan Pawar has already spoken about that, so I'm not really going to talk about this at all, except that this is my contribution to dentistry. This is the chapter in the Springer published Lasers in Dentistry Current Concepts, which is a textbook on contemporary dentistry, edited by Don Caluzzi and Stephen Parker. And I have a chapter in it, and that's really my contribution. As you can see, I don't like competition. And this is me, not that long back, about 2 or 3 years back. Anyway, let's look at the components of digital dentistry. What is it that when we talk about digital dentistry, what is it that we're talking about? You're looking at data capture. So you're looking at CBCTs with facial profiles. Then you're looking at data capture intraorally, which is intraoral and lab scanners. You also need a planning and treatment software to plan the cases. You can use 3D printers to get temporization or surgical guides or temporary solutions. You have CAD/CAM milling units for the final restorations. And then, of course, there are lots of restorative materials, blocks, and discs available in the market. And so it's important that we understand the differences with all of those. And very importantly, you will need ceramic and sintering furnaces to finish the restorations. So this is the whole aspect of digital dentistry. So it's data capture, treatment planning, and manufacturing of the final prosthesis. So let's look at what we have in our practice. We, of course, have CBCTs with LATSEFs. We have digital scanners, multiple. We have the treatment software, which can plan it. We have, again, multiple softwares available. And then we have multiple milling units. We have a 4-axis milling unit. This is the CEREC milling unit. And the earlier one we saw is the 5-axis milling unit. And then, of course, you have the zirconia and the ceramic furnaces, which will allow you to finish the restorations. So this is your entire gamut of armamentarium that you will need for digital dentistry. What are the uses of the digital workflow? So it's all encompassing. You can only do diagnosis and treatment planning if you have a CBCT, and then you will plan it. If you have special software, planning software for implants or crowns, you can do the treatment planning, and you can then relay that information to your lab, who can then give you the final restoration after taking your diagnostic and treatment planning files. You can use it for orthodontic and myofacial appliances, and today you know that invisible orthodontics is the rage, and there are a lot of companies which are making aligners and myofacial appliances which are either 3D printed or they are milled. You have implant dentistry, and there is a whole gamut of uses of digital dentistry components in implants, from data capture to final production of the prosthesis. Aesthetic dentistry, one-visit dentistry is something that we never thought would be possible, but now it's amazingly possible. You have, in aesthetic dentistry, you have inlays, onlays, veneers, crowns, and bridges. So as you see, it is all-encompassing. It covers the whole gamut of solutions in modern dentistry. And really, post-COVID, this is something that you will really have to look at. Because if you look at digital impressions only, planning and impressions, then you're not taking impressions which will be transported into labs and stuff like that, wherein the danger of transmitting the virus exists. You also can do one-visit dentistry, which will allow you and the patient to be more comfortable rather than coming a number of times into your practices. So we will look at all of these options. What are the advantages of digital dentistry? Digital data capture, so no distortions, ease of use in designing restorations, accurate milling and 3D printing, and therefore you're minimizing the human errors, you're reducing the timelines. And this is, again, extremely important, as in today's world, apart from COVID, people have no time to spare. Time is money, and the lesser you call the patients into your practices, the happier they obviously are. So let's look at the digital workflow first, and then we will take you through the entire gamut of cases that we can work with digital workflows. So the digital workflow will consist of data capture, treatment planning and design, material selection, and production. So the first step would be data capture, which will be either in the form of a radiographic data capture, so in the form of a cone beam CT, and then it can also be in the form of data capture of intraoral data capture of the teeth. So this is data capture of a tooth, and then we are planning the restoration. So this is the data the planning. So I'm going to sometimes cut short the videos because these are pretty large videos. So we are planning the restoration on the data captured treatment planning in the patient's mouth on our computer. This is done at the same time that we've just taken the data capture. And then we will align the block in this is the block. As you can see, this whole thing is a block of you can use different materials. You can use Emax, you can use zirconia. You can this is a monoblock zirconia that we're going to do it in. And this block you have to fit your crown in, and then you give a little signal to the machine, a little command to the machine to start the milling protocol. And So that is the whole gamut and in which you're doing it. So you're doing the data capture, you're doing the treatment planning, and then you're going to mill it by selecting the correct restorative material for that particular patient. Intraoral scanners. There's a lot of confusion, and I got a lot of questions about intraoral scanners. So my scanner is better than yours. What we have in our practice are these three scanners: the CEREC, the CareStream, and the Medit. Today you have very quick scanners. The Prime Scan from Dentsply Sirona is amazing because it can do a full arch in about 2 minutes. It's very accurate, but also there is a cost attached to it. It's very, very much more expensive. So whatever fits your pocket, most scanners work well. You need a color scanner, of course. Don't buy a monochromatic scanner. You need a color scanner which has a reasonably quick production capture value attached to it. So there is nothing like my scanner is better than yours. It just should fit your pocket well, and it should be able to do whatever you need to do in your practices. So this is the scanner that we are using. We scanned it for 2 veneers. You can have a look at this case. So once we've captured the image, then we are going to start planning it. And this is a very important aspect of it. You must have a good software. Of course, if you have a full system like the CEREC, it will come with its own software. Or you can just get one of the external softwares available, like the ExoCAD, for example. And there are many others available in the market, and all of them do a pretty good job. Some of the scanners themselves, like the 3Shape, will come with their own scanning software, and that will aid you to plan. And so, please, before you buy anything, go into all the nitty-gritties of what is available in the market and what suits both your pocket and your usage. Because there might be that you will overbuy something in terms of its pricing, and then you don't really need it. So once you've planned it, this is a 5-axis milling unit. For veneers, we find this a very effective milling way. The difference between the 4-axis milling unit, which was the CEREC one which you will see, and this one, which is a 5-axis milling unit, is that it can give you the screw axis hole. Also, this one uses discs rather than just blocks, which the 4-axis one that we have, which is the CEREC one, uses. So it's a little bit more reasonably priced to the lab, to you, if you're the lab, which is what we are. We do all our lab work, which is full ceramic in-house. And there you have, the veneer is ready, and you can just remove it from the sprue, and then you can put it in your furnace. You want to add some, you can do that. So again, like I said, there are 2 kinds of milling units, 4-axis versus 5-axis. Unless you're doing implant prosthetics with screw retained implant prosthetics, which is different angles, you don't really need a 5-axis milling unit. If you're only going to use it for crown and bridge work and things like that, for veneers and stuff, your 4-axis is good enough. So don't spend that extra money if you're not going to use it, because it will just be an added burden in you without actually paying you dividends with the kind of work you're going to be doing. And then you have the ceramic furnaces. Those you will need if you want to modify the crowns. Or you're doing layered zirconia crowns. You will need those to do that, and of course to glaze ceramic. And then you will also need zirconia furnaces to temper the zirconia, to crystallize the zirconia. Okay. We also have a lot of restorative materials that are available to us, and it's very confusing. And I have some articles that I will talk about a little bit later. So this is in 2018, Journal of Dental Research. The restorative materials available are the PMMA, which is supposed to be a temporary material. Then you have the composites, the tetracrad. You have the feldspathic and the lucite ceramics, which is the Empress. You have the lithium disilicates, the Emax, the zirconia reinforced lithium disilicates, which are a mix of zirconia with lithium disilicates, or you have resin matrix ceramics, which is a mix of resin and ceramic, which is enamic. And then you have monoblock zirconias, which are very strong, 900 to 1200 megapascals. So if you look at the amount of strength these materials have, the problem we've had in our practices, and this is something that nobody talks about a lot, and I'll show you a shocking study which is published by the Clinical Associates, Research Associates of Gordon Christensen, is that all of these composite materials, the zirconia reinforced materials, or the resin matrix ceramics, the failure rates there are very high. So what we have now done in our practices is that we are using the basic, we use a lot of the Emax, the lithium disilicates, we use Empress CADs for veneers, and then we use zirconia, and we also use Emax for crowns. If it's a single crown, up to the sixes, we use lithium disilicates, and if it's a bridge, then we either use layered zirconia or monoblock zirconias. So that's what we have in our practice, and we look at some of the articles that have come out in papers that have been published in the recent past. So again, this is a lot of inventory that you will have to keep if you're going to keep all of these materials. So make your life simple. Make sure that you understand what you're getting into and buy only that which you really need. You also need luting cements for ceramics and zirconia, and I will show you some cases that we've done with how to lute, because this is one of the most important steps for all ceramic materials. You're actually bonding it to the substrate, to the substructure, either its tooth structure or its implants. You're bonding it to that abutment, whether it's tooth or it's implant. And so it's important to understand what materials to use. So Variolink Aesthetics is a very nice material which I use for the anteriors. We use a speed sem for most of our bonded cases, which is a self-curing material. And the Variolink is a dual cure material. So everything that we need is available. Today's market, you can also use GC modified, resin modified GC materials, but I prefer to use materials which are bonded, which are bonding to the substructure. So let's look at some of the cases. That's enough of theory for you. Let's look at some of the cases that we can do. And these are all done in our practice with CAD/CAM materials, except one case, which was done in the first, because there's a 10-year follow-up of that case. I want to show you how sustainable a zirconia restoration can be if done properly. So maxillary and mandibular veneers, as you can see in this case, this is a patient who came to us like this. These were supposed to be permanent veneers, and they have discolored very badly. They were some kind of composites that were used in the patient's mouth. And of course, we had to redo the veneers completely for her. She also wanted to close the diastemas on the lower. And so we did veneers on the upper. So we did the CAD design. So computer-aided design. What do you mean by CAD/CAM? Computer-aided design and computer-aided manufacturing. That's exactly what we are doing for all our cases in today's world of modern dentistry. Okay, so we do a CAD design of this. For the lowers, you can see that Your preps have to be consistent. You can do minimal preps. And so this is a lot of minimally invasive dentistry. And this is the nice result that we get post-operatively. These are EMAX veneers because of the patient's slightly deep bite. So we didn't want to use, so you have to use a slightly stronger material. We use a lot of feldspathic veneers for, which are the best aesthetic veneers that we have. Okay. So next case is, again, in this case, we are going to do something. This patient had hyperacidity, and she must have had a regurg because there was a lot of wear pattern, especially in her anteriors. So we had to do veneers from the palatal. Is that possible? And of course, we had to design her lower teeth as well. As you can see, the wear pattern in this patient. So we had to do crowns in the anterior, and we had. So this is the lowers. We restored her lower dentition with crowns. We did crowns in the upper maxillary central incisors, and then we did palatal veneer preparations. This is absolutely stunning if you have a CAD/CAM unit, because this is very difficult to do with conventional impression takings and so forth. So we did palatal veneer preparations. You know what the ease of this is, that in case, so these are our preps, in case you are you feel that you need to modify it, then after you've done your digital scanning of the impression, you can check on the computer and to see that what modifications do you need further. And if you need to do that, you can just go back to your patient at the same time. So you don't have to keep taking impressions if you want to improve your preps. So that's one of the major advantages of doing this. And once you do that, you can correct that mistake in the preparation or advancement in your preparation, and then just rescan only that particular tooth. Just loop it out, rescan it in a particular tooth. Once you've done that, you have your scan back again, and then you can start planning for the patient. So you're doing the treatment planning. As you can see on the upper slide, those are your crowns and veneers, the palatal veneers and the crowns. I would have loved to do the full arch veneers for her, including the crown at the back. But, you know, in India, cost is a major concern. So the patient did not want to change that, even though I've been trying to convince her to change both her crowns and the sixes. So we had to match the shade to the existing dentition of the patient. And this is post-operative. This is in the patient's mouth post-operative on the model. And this is post-operative. So you can see nice soft tissue emergence and aesthetics with these veneers and crowns. Another case, and this is a composite veneers, and there were two crowns in the anterior, just 1 year old. This patient is an actor, and she had a lot of inflammation around the central incisors and the lateral and the canine on the left-hand side, left maxilla. And so obviously we had to remove her composites. These were permanent, supposedly permanent composite restorations and crowns. And then we had to lase. So again, giving you a teaser of this, we will talk about this in the laser webinar that we will have, which is the last webinar in October. So you remove this, you lase that area, you take the scans, and this is done in 3. Immediately post cementation, and this was, we only waited for a week post the lasing. This is immediately post cementation. This is 1 week post op, and you can see that we've got a nice soft tissue a margin around the veneers now. So the healing with lasers is also very quick, and these are non-invasive. We don't have to use a scalpel at all. They don't need sutures. So again, I will talk about that. And this is a 3-year post-op result. You can see just very mild inflammation around the centrals, but the result long-term looks very, very good. Another case. By the way, I will be discussing some of your questions. So my presentation will last for approximately about an hour, and then half an hour we will discuss some of your the poll results and some of your queries and questions that you've been directing towards us. Okay. So preoperative case, of course, the ideal treatment plan for this case would be, he's an actor, would be orthodontics, and then followed by maybe tooth whitening and or veneers on top afterwards. But since he was doing a film and he didn't have the time, and he has a very gummy smile, as you can see, and he has a high lip line. So this is one of the more difficult cases with veneers that you have to treat, because your emergence profile has to be really very good. So the first step in this case would be to do crown lengthening. You will have to do soft tissue and osseous crown lengthening. So soft tissue gingival crown lengthening along with osseous crown lengthening, and it is very easily doable with your erbium family of lasers, which we use to go through. So we don't even open a flap for this. We just go through the soft tissues, and so that I will again talk about that in the laser lecture in absolute detail. So first we mark the soft tissue with your laser. You can check how much of the free gingival margin you have, and below that, of course, is the bone. So if you're going to do that much of crown lengthening, you will have to do osseous contouring to then relocate your marginal gingiva and have a band of tissue there, which will be able to sustain this gingival this gingival margin long term. Okay. So you are also pushing your osseous tissues back along with your gingival tissues. That is post crown lengthening, and we go through the marginal tissues, through the pocket, and reduce the bone. And now, after so many years of experience with it, there are enough foolproof methods of doing this, and we have written a lot of articles in this as well. So if somebody is interested, they can email me, and I will send them the articles that we have published on this. Once the healing is done, and we had to do this in a bit of a hurry because the patient was ready to shoot. So this we did, I think, in about a week's time. Normally, we would wait for up to 2 to 3 weeks. 3 weeks would be ideal before we take the impressions for the final veneers. But in this case, we had to do it a bit earlier because he was shooting. So we did the preparations, and this is post-operative. So this is post-operative about 10 days down the line. Again, you can see a beautiful emergence profile for the veneers. And this is post-operative. And this is 2 years post-operative along with the preoperative. So a very nice aesthetic result to end with. And this would not have been possible with modern technology, with lasers, one, and two, with the digital dentistry that we are now incorporated in your practices. We've actually had the scanner and the CEREC unit from 2010. So it's been in our practice for 10 years plus now. Okay, so what do the review of literature say about what are the materials available for in-office crown restorative materials? This is a very new field, and so not a lot of papers have been published on this. There's been a lot of recent interest in these materials, and so this is the first clinician's report that I've actually seen. It is from Gordon Christensen, and the results are stunning, actually, if you see it. So what they're saying is that zirconia, the results survival date is about 100%. And if you go down and if you see the hybrid materials which are mix of zirconia and ceramic or mix of resin and ceramic, those materials have large failure rates. For example, there is one material with a 24% failure rate. Some of the others have 11% failure rates. So if you look at the summary of the 2018 results, they actually looked at three: terminal fracture, cementation failure, and greater than expected opposing wear. So in the zirconia, the terminal fracture had no terminal fractures in 1 to 8 years. In their practices, cementation failure, there were about 10% zirconia failures. What is it telling us? That is too much for me. What is it telling us? That we have to improve how we cement zirconia crowns, including doing sandblasting. Okay. There was the new cement, and their study shows that the new cement that Ivoclar has introduced, the SpeedSem, has shown better results with the Zircad material that is also manufactured by Ivoclar. There are other materials that are available, of course. Greater than expected opposing dentition wear. So if you look at 1 year, a lot of the opposing dentition wear happened with zirconia crowns. So again, that is something that we will have to look at in detail in the future. In the glass ceramics, which is a hybrid material, you have a large failure rate or fracture rate of 26%. And that is consistent with what we have in our practices. There was not so much of cementation failure, and it did not have any greater than expected wear on opposing dentition. The ceramic polymer had 2 to 4% terminal fractures, but it has a larger cementation failure. So again, we have to understand, and that's why we are going to start. So we have introduced digital dentistry in both our programs, in Manipal and in DY Patil, as a part of one module, and the students, are allowed to design their restorations. They are taught how to do scanning, and they're also given demonstrations on abutment, milling, and the final restoration. Because there is a lot of confusion as to what we can do and what are the materials that we should use and what is the review of. So if you look at the cementation failure of ceramic polymer, that is too high. And all of them had the same amount of, except for camouflage, which I haven't used. So, of course, they didn't have any greater than expected wear. So therefore, the problems with the hybrid materials exist, and until they're sorted, we have stopped using them in our practices at this point. Okay? So, if you understand this, you will have to make sure that you do something. So if your patient is a Brooks, you will use zirconia, but then you will have opposing wear. Sometimes it might be better to just use a metal ceramic restoration. So we have a poll. Everybody on this program, there's a poll dialogue box. If you can just open that dialogue box and fill up that poll, it will help us understand and design our courses in the future so that we can concentrate on areas that we should look at. Okay? So, what about digital implant dentistry? That was aesthetic dentistry, and we will talk about, even in the next two modules, we will next two webinars, I call it modules, but they're webinars. We will talk about aesthetic dentistry, because aesthetic dentistry is a part and parcel of what we do for a living. When people talk about dentistry, shouldn't it be aesthetic? That's how I look at dentistry. Digital implant dentistry, you will have the surgical guide fabrication. You can do the abutment milling with it. You can temporize with your CAD/CAM restorations and your 3D milling units. I'm sorry, and with your milling units, and then your final prosthetic construction. Okay, this is all done with digital implant dentistry. The first step, of course, is the data capture, which I'm not going to go into, because we're going to do data capture and the treatment planning for the surgical guide fabrication. Again, I don't use the surgical guide in a lot of cases. I use it when I really need to use it, or when the patient demands a one visit dentistry complete from start to finish. So this says we can do something like this. And you can use all kinds of software for the surgical guide fabrication. We use the Nobel Guide in our practice, and we use the ExoCAD. So these, both of them have implant model. Of course, the Nobel Guide is an implant specific software. The ExoCAD, you'll have to buy the implant module. If you're using some other scanners, then those will give you the software. This is a Blue Sky Bio software, which also can be used. This is a company where you can order it online. Most of these softwares, you can place an order with your labs online. So what we're doing now is to plan the position of the implant on the software. So you're doing the positioning in both the buccolingual and the mesiodistal angulations. Make sure that you position in exactly the ideal restorative position, because please remember, implant dentistry is not a restorative, it's not a surgical option. It is a purely restorative option. The patient does not care what implant is placed in his mouth, as long as you do a proper restoration in the patient's mouth. And now we are getting the extent of the guide. So we are planning for the extent of the guide, because the guide will have. So the most important thing here is the stability of the guide. If your guide is unstable in the patient's mouth, your implant will go in at any odd angle and you will have a failure again. Or your positioning of the implant will be wrong. This is a very important step. In this case, we are taking the help of the neighboring dentition to position the guide and make it stable while we do the drilling protocol in the patient's mouth. I'm going to show you one case immediately after this. This is a full arch case wherein we use anchor pins. And you can use your 3D printer to print a guide. So we have a 3D printer in our office as well. We use it mainly for temporization and some of the few cases that we need to use the guide on. This is a guide this is a Nobel guide manufactured by a Nobel Biocare Procera unit. And so we are placing 5 implants through this. So it's a guided surgery. It's a full guided surgery all the way up to the implant placement through the guide. You can also use guides to just give you pilot drill guides. You can get pilot drill guides. You can get initial guides only, or you can get the full guide. This is a full guide. And because it's an edentulous guide, you will need a great stability. And so therefore, we use anchor pins to begin with. And this is the video of that. This is a long video. I'll cut it short once we start the protocol. That's a patient which is anesthetized. Remember, you have to trust the software and the guide, because you are not using you're not even opening a flap, and there are no sutures involved in this. Okay, so that's the first step, was the anchor pin placement. Once we've placed the anchor pins, we start the drilling protocol through the sleeves. This the first drilling protocol is a tissue punch, because remember, we haven't opened the flap. So the first step is the tissue punch. So we remove the tissues. Then we start drilling through the guides with these progressive guides. So we first start with the pilot drill. Then we go with the narrow platform and the regular platform drills. Once we've done the first implant placement through this guide, We're doing a screw tap, and then we will place the implant. Once we place that implant, we will also use an anchor abutment there, so it will fix the guide even better. And we will do it on these two middle implants. So the one lateral to the middle implant mesially, and the one lateral distally. Okay, so those are the guide sleeves that we are using, progressively wider into your guide, which is in the patient's mouth. Once we've done that, then I'll go forwards. And these are the two, what they call template abutment or anchor abutments. Okay, because they will also fixate the guide. And then we go in and place the implants in the other three areas. Okay, so here the most important aspect of this procedure is the stability of the guide. If your guide is unstable, please do not go ahead with the procedure. Then you're much better off opening a flap and doing a freehand surgery. So once you've done that, and we're going to also take the impressions for the temporization on the same day. These are open tray impressions. We keep the temporary ready. It's a full acrylic temporary, which we manufacture in 24 hours. And you see the soft tissue closes up so quickly around the implants that we have to, after 24 hours, we have to go in and remove the soft tissue and then place the temporary prosthesis in the patient's mouth. So this is immediate loading protocol followed, and it was aided because we had a guide. Okay, we can also do implant-supported prosthesis with the guide, with the digital dentistry protocols. So the first step in this is to take a scan of the implant in the patient's mouth. Then we will use scan bodies and take a scan of the scan bodies. So the scan body and so the software can then judge where the implant position is and where the scan body fits in, because it has a library of scan bodies that the software has. And that's your scan body, which you can place in the implant, and you can scan that. And so now the software will know exactly where your implant position is. And then you can start milling your abutment, or you can use a stock abutment and then make a crown on top of it. In this case, we're going to use a stock abutment. In the next case I'm going to show you, we're going to mill the abutment. Okay, so these are the two implants. This is the intraoral scan body. We've taken the scan body. We're going to design the crowns. Now you can take a stock abutment, and because the library of the software has a library exactly of the same abutment, you don't have to take a scan of the abutment. The library will allow you to visualize exactly how the abutment will look on the model, and then you can plan for your final prosthesis. As you can see on the lower right, that is your final crown. And then once you've milled your crowns, you can just take your stock universal abutments. These are intraoral with the universal abutment, place them in the patient's mouth on the implants. And then once you have the crowns, you can try the fit of the crowns, you can try the occlusion. Once you have them, then you start the cementation protocol. The cementation protocol is very vital to this. We are cementing these. So you'll ask me, how is this retrievable? You'll see how it is retrievable. Because what we're going to do is we're going to cement the crown in the patient's mouth and then unscrew the crown from the implant through the screw access hole, because we want to clean the excess cement. One of the main areas of problems with peri-implantitis is the cement which is extruded around that area in the patient's mouth. And so we remove it, we polish the excess cement, remove it, we polish the restoration and the crown, and then we screw it into the patient's mouth. You'll see this in this case and in the next case as well. So this is important. We are bonding this. We are etching it and then bonding it.
Sorry to interrupt, but there's been a lot of requests to turn the music down during the video.
Okay. Okay, is that better?
Yeah, much better.
Is that better?
Yeah, that's fine.
Dan, can you answer me?
Yes, that's fine.
Okay. Can you still hear me, bud?
I can hear you clearly.
Okay. So then we are actually etching. We are using silane, and then we're going to bond it to the universal abutment that is there in the patient's mouth. So these steps have to be followed properly. The protocol has to be established. Follow the manufacturer's instructions to the T. And now we are using the self-curing cement, which is a composite self-curing cement. And now you see how we still are able to retrieve it. So we are going to go into the patient's mouth, and in the universal abutment, we're going to place this crown on, ask the patient to bite, and remove the cement from the screw access hole. So make sure that the occlusion is maintained properly. Remove the excess cement from the sides as much as you can, and go into the screw access hole, as I'm doing right now. I'm going into the screw access hole, removing the cement, and then we've of course blocked the screw access hole with either cotton or duct tape. And then we just removed it and asked the patient to bite in it, and then do the full cure. I'm sorry, this was a dual cure cement. It's not a self-curing cement that we've used. And while it sets, again, you will cure it, and then you will slowly dislodge the crown from the patient's mouth. And there it is. You've dislodged the crown from the patient's mouth, and you will see that there's some excess cement which you will polish. Because if you leave composite cement in contact with the tissues, you will get peri-implantitis. So this is a very important step. We'll again cure it, and then go back in and cement and screw in the crown in the patient's mouth. So this is one of the few articles I've seen, and this is Marcus Blatt's, my friend's article. Clinical long-term studies indicate that porcelain, veneered alumina, or zirconia full coverage crowns have high survival rates when inserted with conventional cements. However, most of the selected studies recommend resin bonding, especially for implant-supported restorations. What is very important is proper pre-treatment of the bonding surfaces and applications of primers, here in this case we use silane, that contain special adhesive monomers, which are extremely necessary. But we don't have any long-term data on raising bonding of partial coverage, high-strength ceramic or monolithic zirconia restorations. And that is why the problem that you had with the Christensen study, where they said that there was 10% dislodgement of the crowns. What we've now come to a conclusion is that you must use very less spacers when you're doing a zirconia crown, and then so we are in the process of doing a study in that. So if you keep that spacer to minimum thickness when you're designing your zirconia crown, then your dislodgement of the crown is reduced quite significantly. We don't have the figures right now, but we will come back and tell you about that. And this is in the patient's mouth. These are the two crowns that we had prepared, and then screw retained crowns. So it's a nice aesthetic result as well. Another case, and here again we are using screw retained crowns, one in the upper, post second stage surgery, one in the lower, intraoral scan. I'm just repeating it so people who haven't understood it will have a look at it. Then we design the restoration. We can see the universal abutment, which is a stock abutment, which is a part of the library of your software, which will give you that placement in the patient's mouth, exactly the same on the computer without you actually having to use an abutment, but you're just using the library of all the abutments that your software will have. The CAD for a mandibular crown, and this is a layered zirconia, as you will see. So there is a inner substructure of zirconia, and which will be layered with ceramic. The weakest link of these crowns is the bonding strength between the ceramic and the zirconia. But sometimes you don't want monolithic crowns, especially if the patient has a deep bite or the patient has a bruxa. I'd rather have the veneering ceramic chip a little bit rather than for it to wear away the opposing dentition. So that's the compromise that you will have to make. And it will have to be case dependent. Then you place the universal engaging abutments, excess cement seen post retrieval of crowns. We use the same methodology as we had shown you earlier. That's the maxillary crown, that's the mandibular crown. And so again, this is what done in one visit. So we can do this now in one visit, so the patient doesn't have to come and stay for many days while the restorations are being fabricated. And this has simplified, especially post-COVID, our lives to a large extent. Zirconia mill, we can also mill abutments. A lot of times, especially in the anterior aesthetic zone, your placement of the implant may not allow you to have a stock abutment, or even posteriorly, when you have a grossly angulated implant and you want to correct that angulation, then a custom-made milled abutment, or if you have a very large collar height, which is not available in stock abutments, how are you going to get the same emergence profile with a stock abutment? In that case, you will have to use a custom-made abutment, and you will mill the abutment. And today we have the opportunity to mill the abutment and mill the crown simultaneously, so that we can do the whole process in one day. So I'm showing you a case where you will find the problem with the stock abutments done earlier. This one was the left implant was not done by us, but I'm sorry, the right implant was not done by us. The patient came in like that. The patient has fractured the central incisor, is a vertical fracture, as you can see. We do an extraction and immediate implant placement. And you can see we've placed the implant in, submerged the implant by about 2 millimeters below the crestal bone in the interdental area. And we have placed it in the palatal aspect. Of course, we've done a bone graft where the jumping distance is. We've placed a temporary abutment this is an immediate implant and an immediate loading protocol. Okay, for a temporization, this is your temporary on day one. And if you see the left crown, you'll see what has happened there. The zirconia abutment, because it was a stock abutment, it had a very large emergence collar. So there was a dehiscence around that area. And you will see what we've been able to achieve in the left one. So that's why I took this particular case to show you that this is a problem that can happen. This is 1 week down the line for your temporary, and now the soft tissue has already healed around the implant. That's your temporary 3 months down the line, 2 months down the line, and this is your IOPA with the 2 implants in the patient's mouth. We then take a scan with the scan body, and we take a scan of just the implant in the patient's mouth. We then plan for the abutment. We are making a zirconia abutment, which we are going to custom design. That's the custom designed abutment. Once we've designed that, we will also design the crown on top of it. That's a custom designed abutment. And here you can understand that we can actually change the angulation. We can make the collar height different. So, and we can make it in different materials. You can make it in zirconia. You can make it in titanium. You can even make it in chrome cobalt. I don't know why you would do that, but you could even do that. And then you can change, and then you can design the crown on top of the abutment as well. Well, you're going to then cement. Well, this is what is known as a titanium base. All of them will have, even if they're zirconia, will have to have a base, which is titanium. So it's called a tie base, which Nobel Biochem makes, or you can get a stock titanium block and you can mill that. You don't get zirconia blocks like that. So we wanted a zirconia crown, so that's why we did that. And now on top of this, we have already designed the crown as well. And that's your crown on the abutment without actually entering the patient's mouth. We've done that. We've placed the abutment in the patient's mouth. This is on day 1. We've cemented the crown. And this is how it looks. I don't have follow-up pictures because the patient did not come back, but I can assure you that the soft tissue will have grown beautifully around that. And you can see it in the other cases. Because this was a case where I had milled a zirconia abutment, I wanted to show you that. And I don't have long-term case results with this particular patient, but the next one, I have long-term results. So in this case, we have an immediate implant placement. We did not load it because the patient did not live in the country. Soft tissue and emergence profile. He was a dental tourist. Zirconia abutment placed. The veneers made 1221 prepared for veneers. And this is the final prosthesis in the patient's mouth. Again, a very nice result. A third case, preoperative intraoral. This is a very young girl. She has a very, very high smile line. And so we had to extract, one of the teeth was extracted. So you had to place an implant in exactly the side, because this is a very difficult case to treat. A smile line is very difficult. So that's a gummy smile. So your emergence profile with the implant is extremely important. So we are going to place the implant and immediately load it, as you can see. And we also did endodontic treatment for the other teeth. We're going to we use a zirconia. This was a stock abutment. We modified the stock abutment a little bit. You can't really modify the zirconia stock abutments a lot, only very little. Sometimes they even fracture. So be careful when you're modifying zirconia stock abutments. So we did gingival troughing and crown lengthening with the laser to get the right gingival zeniths. And this is immediate post-cementation. And you're looking at me and saying, what is this? You've got spaces in between your teeth. See what happens 6 months down the line. We follow the Tarnow principle. See what happens. This is on day 1. This is 6 months post-cementation. And now you have a nice emergence profile. And because the patient has a very high smile line, this is extremely important. And you cannot have a dehiscence here. So you have to actually make the abutment. In this case today, this was a slightly older case. And this is done about maybe 7 years back. We didn't have the wherewithal to do zirconia abutments, which you could mill, custom abutments. So that is why I use the stock abutment. Otherwise, today I would definitely do a milled custom abutment. Anterior abutment with ASC crowns. And this is a angulated screw channel crown. So that if you want a screw retained restoration in the anterior region, and your screw access hole is coming out from the incisal or the buccal, then how do you tackle that? This is the only way to do it. You change the angulation of your screw. So it's called an angulated screw channel attachment, which Nobel Biochem makes. So that's one of the companies that I do implants with. There are other companies that I do implants with, and we will talk about that when we do about the advanced implantology lecture next time. So this is the removal of the cyst in this patient. She had a big cyst here, as you can see in the OPG. Cyst removal, we curated with a laser. We did a bone graft and placed an implant in. And now we are designing the prosthesis. Now this, if you see the abutment, it has a long screw channel, and the crown is held by the screw channel, which actually is angled. So this, even though the implant was angled and the screw axis would come out from the buccal, because we could angulate the screw channel, and this is very important, and this is only possible with CAD/CAM dentistry, and that's why I've included this in. It's called the ASC crown, that we can change the angle and go from the posterior, from the palatal, not posterior, palatal, and have the screw axis hold for that. And this is the final prosthesis intraorally. This is on day 1. This is the final prosthesis on day 1, and this is 3 years down the line. So again, a very stable prosthetic solution. Another case, and this I want to show you because this is one of my very old cases. I have 10-year follow-up with this case. This is iatrogenic dentistry. The post score was done in the patient's tooth root, not in the patient's tooth root, but in the soft tissue. So there was a lot of infection there. Atraumatic extraction. We placed immediate implants. We did bone graft and a membrane. And immediate post-operative. 2 months post-operative. Now you can see and you can appreciate that we just do not have a emergence profile for this particular patient. So we have to generate the papilla and the emergence profile for this patient, and we'll see how we do that. We place the abutments after the impressions. This was a stock zirconia abutment. We had a stock titanium abutment. This is more than 10-year back case. And so there we didn't have the opportunity to do milled abutments at all. Immediate post-cementation, and we did low level. We'll talk about that in the next laser module. And you'll say, you're mad. What's this? There's spaces in your teeth. And look what happens after 6 weeks. You already have a beautiful emergence profile around the bridge. After 6 weeks, after 8 years, and after 10 years, it is still surviving exactly in the same position in the patient's mouth. You can also use CAD/CAM digital dentistry for a case like this. If you look at the preoperative case, she has a missing lateral incisor. She has a peg-shaped lateral incisor on the 2-2, and she has a diastema, midline diastema, which needs to be closed. So obviously, the options are that we will need implant in the 1-2 area, but we need to close it orthodontically. So we use CAD/CAM aligners. This is preoperative. We use CAD/CAM aligners to close it. And then once you've closed the space up, you will place you place your implant, place the abutment, which is a zirconia abutment, and you place the single visit crown, and a veneer was fabricated for her. And this is post-operative. So a very nice result from the top to the bottom, and all of this using digital dentistry, including CAD/CAM aligners. Another case, we're doing a sinus lift for this particular patient, and I'm going to show you this. I'm going to talk a lot about the sinus lifts in the advanced implant modules, with a lot of video presentations and immediate simultaneous placement of the implant along with the sinus lift, and also talk a little bit about the failures with sinus lifts. What are the reasons for failures and how you can correct those. So I'm not going to go too much into detail with this, but we're making Ringer's lactate. We're then judging the length we're using. But this I'm going to talk because we're running short of time now. So I'm going to talk a lot about this in the advanced implant lecture, which will be next month on the 20th of September, which is also a Sunday, and it'll be at the same time at 7 o'clock in the evening. We're also running two programs on laser dentistry in Manipal and on implant and laser dentistry in Dr. D.Y. Patil in Mumbai, which is a 6-module program, which will train you in basic implant dentistry, and you will also get to see very complex implant procedures. So once we've done the sinus lift, and we've done the drilling protocol for the implant, we're doing a simultaneous implant placement. We then place the graft material before we place the implant, so we can press the graft material onto the palatal as much as possible. Then we place the implant in. And you can see that we've packed it up, compacted it quite nicely so that the graft material will extrude from the buccal area a little bit, always overfill the graft material. Then we use the cover screw. And then we will compact the graft material completely and fill up the sinus area completely. And then suture up on top. Okay, and that's the post-operative CBCT. You can see we've placed an 11.5 millimeter implant. This is, you can take an open tray impression, you can take a scanned impression, whatever you want in your practice. This is a model. We've placed a universal abutment. We've done a CAD/CAM crown. We've cemented the crown in the patient's mouth. We're now removing the duct tape, which is not allowing cement to flow into the screw access hole. And then you take it out, you polish it. And that's with your abutment. And that's the final restoration in the patient's mouth. Okay. We have 2 or 3 more cases left. And this is, again, a very, very comprehensive CAD/CAM full mouth rehabilitation for this particular patient. She had a impacted canine, fractured 1.4 and 1.5. So we had to extract all of that. And of course, as you can see, she needed implants in the other areas as well. And then and she wanted to get a smile design done as well, so improve her aesthetics. So we extracted the 1.4, 1.5. We did the bone graft because obviously there was a big defect there because there was no canine and there were no premolars were out. We placed implants in the other areas as well. And then once we'd done the bone graft, post the extractions, we went in and placed the implants. Immediate post-implant placement. Because we didn't have any attached gingiva. Imagine we've had to do that impaction, so there was no, and you can find that this is a very common finding, you have no attached gingiva there. How am I going to give her a proper prosthesis? So I did a vestibuloplasty in this particular patient, and I'll show you that when we talk about the laser module. That's one of the areas in which I have been invited to speak all over the world, including at the Harvard School of Dental Medicine for this particular procedure, because this is something that I have, this is my protocol, and I've written and spoken a lot about it. And we then get a nice band of attached gingiva, which we didn't have earlier. And we do crown lengthening in the anterior to get the good zeniths, again with a laser, with an erbium laser, and this is the final prosthesis. And we will talk about this case in detail in the module, in the webinar that we're going to do next time. Okay? And that is the post-operative. That is the post-operative. Okay, this is, and I'm going to show you 2 implant cases, and then we can take questions from the audience. This is a very difficult case to treat. This is a multidisciplinary case with laser dentistry, with bone grafting, with a full arch fabrication, prosthetic fabrication. So the patient came to us like this, infected implants. I don't know what. So when we opened up preoperatively, we opened up and we removed all the implants. There were big dehiscences in those areas. You can see big defects in there. We had to do implant removal and bone grafting. This is 6 months down the line. And now you can see that there is a nice bone growth there after our successful graft procedures. And we will talk about the graft procedures in detail in the implant advanced implant lecture. We did some immediate implants and then other delayed implants in this particular patient. Immediately after implant placement, 6 implants, and we are doing. Now, again, we have a problem because we don't have a band of attached gingiva. So how do I do that? We will talk about that again in the final module. We're going to discuss the vestibuloplasty, which is minimally invasive. And by the way, we don't use sutures for this procedure. This is immediate post-operative, and this is a video. You can just have a quick glimpse of it because we are short of time for this. So we are going layer by layer. I'll show you this whole video. It's about a 10-minute video. We're going layer by layer up to the periosteum and scoring the periosteum where we want the attached gingiva to form. And you can appreciate that there is hardly any bleeding from any of the tissues. That is after 1 month, and we've got a nice band of attached gingiva now. So we've already placed our implants. Now we have the band of attached gingiva as well. And we're going to open the implants. We're using lasers. We're using an erbium laser on one. And that was the erbium, and this is a diode. And again, I'll talk about this in great depth. And this is how it looks immediately post-operative. This is immediate after implant opening post-operative. This is 1 week, so the healing is both the same. So whether you use an erbium or a diode, the long-term results are the same. 1 week post-operative, the final prosthesis. This is a CAD-CAM prosthesis, which is a titanium substructure with an acrylic superstructure. And this is a final screw-in hybrid. This is a final prosthesis. This is a final prosthesis. This is a final prosthesis in the patient's mouth, and a very happy patient at the end. And 3 years post-op, you can see that we've been able to manage to keep this prosthesis very good and clean. And we always remove it after 2 or 3 years to make sure that there is no accumulation of plaque or any debris. And we can also use aids like this to clean. A lot of companies are making these under implant brushes. The last case. So we can do very difficult cases. This patient was a chronic pan chewer and pan parag eater, and obviously you see he's worn down his dentition. He also had carcinoma, squamous cell carcinoma of the buccal mucosa, which was treated. They did a partial removal of the alveolar bone, so a partial alveolectomy. We did his implants. We did immediate implants for him. And again, I'm going to show you this immediate implant placement, and then we will discuss this in detail, just giving you a feeler for the final prosthesis in the patient's mouth. And we will discuss this again in detail in the next module. So this is before and after. And last case will be a zygoma implant case. Again, we will discuss this case in detail. Full ectodermal dysplasia, total anodontia, a very rare case, done many years back, and we just had the patient come back in because he broke one of the screws that held the prosthesis together, so we just had to change it. And this is 13 years down the line. So occlusal view in the final prosthesis, maxillary and mandibular prosthesis, the final prosthesis in the patient's mouth. This is 1 year post-operative. This is pre and post. And again, thank you very much. I hope you enjoyed the presentation and to understand what digital dentistry can do to us today. So I'm going to stop this. I'm going to stop the share. Okay, Dr. Siddhant, do we have any questions?
Yes, we have a few questions. I will just read out some of them for you. There was a lot on the scanners. So one of the most common questions was, what scanners do you suggest? What softwares? And what are the economics of it?
So there are a lot of scanners available in the market. There are some Korean scanners available, which I have in my practice. So like I said earlier, I have a Medit scanner, which I use. I have used the three shape scanner, which is a very good scanner. Um, and I have the CEREC scanner, which is a brilliant scanner. The Prime CEREC scanner is a really, really upmarket scanner, which can scan a whole arch in 2 minutes. So depending on your pocket, and I have a Carestream scanner as well. So depending on your pocket, you should go in for the scanners, and depending what you're going to use it for. If you're just going to use it for capturing the data, then any one of the scanners that I've mentioned, the speed will be different. So if you have a very busy practice, and if you have a very upmarket practice, then you should go in for an expensive scanner. Otherwise, even the other ones, which are slightly slower, will work. I mean, I have not had a problem that has told me that a scanner is it's not giving you the right results. Of course, the high optical scanners, the more expensive ones, have high optics, so their accuracy of the scanning will improve. And so, obviously, if you can afford it, go in for the best. That's one. And two, what is the second part of the question, Dr. Siddhant?
So what softwares do you suggest? And what are the economics of both the scanners and the softwares?
Yeah, the economics of the scanners, I think I've just mentioned.
Yeah.
The software economics is very simple. There are a lot of, I think there are a lot of companies which are charging you per year for this, for using their software. I think those one has to avoid, because I don't know, they can keep increasing the rates of those softwares, and for the scanner software, if you have to keep paying a yearly fee, subscription fee, I think that one should look at that in detail, because the economics of that is a problem. Because it's not in your control, and the company can keep raising those prices, and then you're stuck with having to pay those yearly fees, both for the scanners and for the softwares. So I would buy a software. Again, let me tell you what softwares we have. We have the ExoCAD software. We have the Medit software. We have the CEREC software. The CEREC software is basically it's a closed system, so it does not allow you too much flexibility with other systems. You need a flexible system which will allow you to use various scanners and various. So it's an open system. I would rather go in for an open system than for a closed system, because unless you're going to use everything from that particular company, then it makes it worthwhile, because that's a closed system there. So I would suggest an open system, like I said, unless you're looking at going fully with that company and using everything that they have to offer. And then if they don't offer something, then you might be stuck. So also, if you can ask those companies to open up your software, then that might help. Okay, any other questions?
Yeah. What is the planning for full mouth rehabilitation?
Oh, you mean
how do you plan? What kind of planning would be required? Whether it be implants or a full mouth rehab case for prosthetic purposes with teeth.
So, I mean, it's a very wide question, right? So it depends if it's an implant, and depends on what is the prosthetic option that you're going to use. You can use something like a Paris bar, and those I will show you in the next advanced implant thing, which is a bar which has got ball attachments on it, and then it's a CAD-CAM bar with ball attachments on it, and it has got a clip in the denture, and so this is for patients that you don't have bone above the premolars in the maxilla, above the premolars and the molars, and you don't want to do a zygoma implant, or you don't want to do a grafting procedure, then you can use a bar so that you can cantilever a bar and your prosthesis will fit on that. That's one of the options that you have. Then you have a fixed prosthesis. So you're designing, again, please understand that all of this, even if you buy a software like the ExoCAD, for example, all of them will have designing modules, and you will have to pay extra for the modules. So make sure that you will only buy the modules that you actually need, and you don't buy those that you don't need. Something like the CEREC software, for example, comes with all the modules, because there's So that's a fixed price you're paying for that. And even Dentsply Sirona is now selling a 5-axis milling unit, so you can, if you buy the whole system from them, and you can do that. For full mouth rehab, it's a completely different module altogether. So you will have to invest in those particular modules. Your designing will depend upon for full arch rehabilitation. Are you going to increase the vertical dimension? And you also have virtual articulators. Again, a module for virtual articulators. So you need to plan for what you are going to be using your software and your hardware for. So once you know what is the usage, then you can go backwards and keep buying the modules that you need to buy. Okay? Does that answer your question? I think that answers the question.
Right? Yeah, I think that'll answer the question. There was one very specific question. What kind of abutment was used for the ASC crowns?
So it's a special abutment. It's called the ASC abutment. It is only it's a stock abutment which Nobel Biocare manufactures. It's called an angulated screw channel abutment.
Okay. And the last one that I want to ask is a slightly different one. What would you do for implants in aggressive periodontitis?
That's a very interesting question. That's a very I haven't seen too many articles which talk about long-term implant stability with aggressive periodontitis. If somebody has a review of these articles, I'll be very happy if you can share that with me, and so I can incorporate that in my presentation. But if it depends if it's juvenile periodontosis or if it is later onset periodontitis. If it's late onset periodontitis but aggressive, then I would not do implants. I would do full extraction, so make the patient edentulous so that the periodontal disease is completely eliminated before I place implants. I will not do partial edentulous treatments in these particular patients because I fear that there will be a cross-contamination, and we know that the same bacteria that the same bacteria that inhabit the periodontal pockets can infect the peri-implant pockets. And we will talk about the peri-implantitis treatments and periodontitis treatments with lasers in the laser module as well. So, but in this case, the first thing I would not do is to do partially edentulous in an aggressive periodontitis case, partial edentulous treatments. I would extract everything and then allow the healing of the tissues to take place, because once there is no tooth structure in the periodontal pocket, bacteria are eliminated entirely, and then place the implants in. So that would be my protocol in these situations.
Yeah, I think that's it. I think those are all the questions. The poll results I will just share with everybody.
Yep.
So what cementation material? As you can see, most people are using modified GIC.
Yeah. So that's what I would correct that anomaly, because for cementing crowns, which are CAD/CAM crowns, you would need, unless it's a zirconia crown. Okay. What's the next one?
Scanners in the practice, 26%. And the votes are still coming in because obviously people haven't seen these questions for now. But so far, only 26% have said yes. Most people,
is a lot, which is 1/4 of the dental population in who's visiting our webinar, and I am very happy to hear that, because I would have expected much lower numbers for the amount of practice. What is we will eventually know what the sample size is and all that. But this is something that is heartening to see, that 25% people, which is 1/4 of the dental population, has scanners in their practice. So they are looking forwards, and they're looking to make sure that they will also be at the vanguard of dentistry, especially in the times of COVID.
Okay, moving on to the next question. Are people using digital scanners? Almost 70% have said 0 to 20% of the time.
Which means that most of them are not using digital scanners. A lot of them, I would say about, I mean, obviously, if there are only 25% people who have digital scanners, then only those will be able to use them, and the others won't be. But what is interesting is, if there is 25% of the people who have digital scanners, then all of them are not using them in every case.
No, so
only 6% are using them in every case. And it would be interesting to then look at this poll and send a questionnaire to all the participants and to find out what is it stopping them from using it in their practices for all the patients. Okay, so maybe they have multiple operatories, they're working on multiple chairs at the same time, but we need to figure out what is stopping them from using it. And this would be a great survey to conduct, and it would really help us to design our courses in the future.
Okay, moving on to the next one. Do you use guided surgery for implant placement? 46% are saying sometimes.
Okay, which is like me.
And about 35% saying never.
So about 20% of the people are very often using guided procedures. And again, it would be very interesting to actually send a questionnaire to everybody, to those, especially those people who are always using it and quite often using it, to find out if they're using it for pilot drilling or for the whole protocol. So I would be very interested to see that. Those who have never used it, also I would be interested. And I would also want to know sometimes. So 46% have used it sometimes. That means at some point they've used the procedures. But there's a 20% population, approximately 19% plus population, who's using it always or quite often. So that would be a remarkable shift from the earlier days. Okay, next.
What kind of material being used for crowns? Mostly PFM, about 60%. Zirconia next, and then Emax is only about 5%.
Again, very interesting poll results. So we are still in the realms of PFMs, even though we have more. And again, I would like to find out why people are not changing over. Maybe it's a cost attached to it. Zirconia monoblock, 17% are using more than layered. Again, I would be interested to know why people are using more zirconia monoblocks over layered, because of the fractures with the. We know that the fracture of the layering ceramic is a problem with the layered zirconia. And the monoblock, that problem is less, but the monoblock is much harder, and therefore the opposing wear will be much more. I'm surprised that Emax is only 4%, because if you think that all the anterior crowns you would do Emax in, at least in our practice, that's what we do, up to the premolars, then it would be, because that's something that will give you great aesthetics and enough adequate strength, great aesthetics, and do not wear the opposing dentition at all. So this is a very interesting statistic as well. I hope we have, so 70% are still using PFMs. And that's an interesting statistic. Very nice, very nice. Okay, do we have more? Yeah.
No, that's the last question. What percentage of your abutments are CAD-CAM custom fabricated? We're just waiting for a few more votes to come in because not a lot of people have answered this question just yet. But again, most of the people are saying they almost never do it.
So most of the people are saying that they almost never do it, that they're using stock abutments. And again, I'm wondering if that the reason for that. And again, we need to then educate people about the benefits of using custom abutments because of the collar heights and the angles in which you can actually get the forces of occlusion favorable to the implant positioning. So for aesthetics, and for also for function, custom abutment would be an would be the way to go. In fact, we will see in the near future. My expectation is in the near future, you will find a lot of dentists will be using custom abutments over stock abutments. Okay, and I think the cost will be virtually similar if you're using titanium custom abutments as well. So only 2% are using 80% plus as custom fabricated abutments, and I suspect that they will have their own milling units in their practices, and that's why the number is so low. Okay, so that was a very interesting poll that we've just had.
Yeah.
And hopefully we will have more people in the as this program goes on and more people view it, that we will have more people voting in the poll. Okay, so so thank you very much for being a part of the program, and I'm handing over to Mr. Anthony Neda, who is the General Manager for Alchem Laboratories, and he will be finishing off this presentation.
Thank you so much, Dr. Pradhan. Thank you for sharing your vast experience and your expertise with the audience. The questions never seem to stress people are having. And we also sincerely thank Dr. Siddhant for moderating the webinar. A big thank you to all the participants as well. And they have come in huge numbers, given the fact that today is a Sunday evening. Alchem is the fifth largest pharma company here in India, and our endeavor is to become the most trusted partners with the dental fraternity. And we've got flagship brands like Clavam, Pan40, and Pandy. Today's webinar was the first webinar in a series of 3 webinars. The next webinar will be in the month of September 20th, and the third webinar will be in the month of October 18th. And to encourage us that we do more such academic initiatives, we request you to give exclusive support for our brands like Clavam, which is a brand of Coamoxiclav, Clavam 625 tablets, Clavam 1 gram tablet, Clavam DID dry syrup. Also, in the current pandemic scenario, many of the patients, they are not able to meet their doctors and go to hospitals to take their consultation. So therefore, Alchem has tied up with a telemedicine portal called as C2C. And C2C is extremely user-friendly, ensures 100% patient data privacy, it's HEPA compliant, and best is it is totally free of cost. So I've got a small demo video. Kindly permit me to play it. It's for about 2 minutes.
Anthony, can I just say bye, and then you can finish off? Can I just say bye to everybody?
Yes, sir.
So thank you very much for attending, and I hope you come in large numbers for the next webinar, which is on the 20th of September, which is the Sunday at the same time at 7 p.m. So again, thank you very much.
Dear Doctor, it's the year 2020, a year that will find its way in the books of history, not just for the dreadful COVID-19 spread, but also for the digital revolution in healthcare that was triggered thereafter. We realize it's going to be the new normal. In our endeavor to contribute towards mitigating the COVID situation, we have exclusively partnered with Connect to bring an extremely personalized and customized digital experience for doctors and make your practice future ready. Connected Clinic will enable better engagement with the patient, educate you through customized and personalized channels, and enhance effectiveness in management of practice. For all, get engaged to Connected Clinic. As a first step in this journey, today we will focus on enabling your own virtual private clinic, 24/7 assistance. All this and much more at zero subscription fee, zero hidden charges, and zero obligation. To top it, we have also added a rich library of knowledge-wise webinars and other medical content across specialties, which can be exclusively accessed over specially curated content. Micro nuggets for quick access to latest medical and scientific share content integrating digital consulting for simple, secure, and reliable digital pathways.
So as you have seen, our C2C platform is extremely user-friendly, ensures 100% data privacy. At the same time, that's free of cost also. So all those who are interested to join, my team members will be in touch with you. Kindly give your consent so that you can be onboarded. So that was from our side. So thank you everyone. Good night. Take care and Jai Hind. Thank you.